the unfortunate fact that I went outside, tried to look for some students for which this master class has been arranged. Some of India's best faculty and some topics which I thought every anesthetist must know by heart. But unfortunately, they have found the venue to be nicer and busy taking selfies. So maybe we would relearn some of the things that we might have forgotten, and let us utilize this opportunity. I welcome Dr. Shumantro Dasgupta and Dr. Nishkarsh Gupta and Major Sibinder Singh to chair the session. Thank you. Now I leave the podium to them and the able speakers and whoever is there to listen to them. Thank you.
Hello. Good morning, distinguished ladies and gentlemen. I welcome all of you on behalf of the organizing committee to this session of RSACPCON 2023 in this city, Kolkata. You may have found the weather is little, hot, but then I must assure you that since yesterday we are having a better weather. Earlier it was even worse. Without wasting much time, the first speaker is, of course, Professor Kundra, and I would invite him to deliver on respiratory physiology.
A very good morning to all of you. It's indeed a pleasure to see some of you seated here and well in time. Thank you very much for being here. I think the webinars have had their say and people are probably tired of listening to lectures. They're more interested in workshops. And I agree. I mean, the lectures have been overloaded on them and they don't find any interest anymore. Fine, talking about respiratory physiology, are there any postgraduates around? If there are, okay, some of 4 or 5 of them are there. So, respiratory physiology, I will basically covering the mechanics of ventilation because it's impossible to cover the entire respiratory physiology like this. When you come to lung mechanics, it is all about movement of air in and out of the lungs. And this requires a pressure or a pressure gradient so that the air can move to the to the airways and also to stretch the lung and the chest. So pressure is required for both of them. And a pressure gradient is more important for the movement of the air to occur from the mouth into the alveoli. So the movement of gas across airways would encounter resistance, and the stretching of the lung and the chest is dependent upon their inherent compliance. So if we have to talk about mechanics of breathing, it is basically in 3 stages. One is a central control. They control the respiratory muscles, and the respiratory muscles in turn produce pressure gradients to produce a respiratory output. So let's talk about one by one these factors which govern the mechanics of ventilation. The central control of ventilation is basically governed by two respiratory groups of centers. One is the pontine respiratory group, which comprises of pneumotaxic and apneostic centers. And the other is the medullary respiratory group, which comprises of dorsal respiratory group neurons and ventral respiratory group neurons. Although they have been classified as inspiratory and expiratory. Expiratory doesn't exist to the best of our knowledge. It's basically in pathological conditions that the ventral group comes into play. So how do the pontine respiratory group of neurons work in control of respiration? The first one is an apneutic center, and if you look at the apneutic center, what it does, it produces a sustained inspiratory effort. It means the inspiration will go on and on till it is cut off. So the pneumotaxic center cuts off the inspiration and ensures there is a normal breathing which takes place. Coming to the pneumotaxic center itself, the role is now defined that it switches off the inspiratory activity. It ends inspiration, cycles to expiration, therefore decreases the tidal volume and increases the rate, which otherwise would have been quite high. So the apneustic neurocenters, which has the switch off neurons, it's controlled by the pneumotaxic center. Apart from the central control, it also has a peripheral control in the form of Herring-Burer reflex. These are slowly adapting stretch receptors, so once the chest wall stretches to an extent, the respiration again is cut off, and this information is conveyed via vagus nerve to the apneustic center. So these are the cut-off inspiratory neurons which exist, the stretch receptors in the peripheries and the pontine neurons in the central nervous system. The apneutic center also stimulates the upper motor neurons or the dorsal respiratory group of neurons present in the medulla. So the medullary respiratory group comprises of two groups of neurons, the dorsal respiratory and the ventral respiratory. As has been pointed out earlier, inspiration is governed by the inspiratory muscles which are involved through the input which is received from the central centers, and it controls the basic rhythm of respiration. The ventral respiratory group is inactive during normal quiet ventilation, and the activity increases when there is lung disease or when the accessory muscles have to be used. And it also controls to an extent the expiratory intercostals and abdominals. So whenever you find a patient who is in respiratory distress, having tachypnea, using accessory muscles, it tells you that now the ventral group of respiratory muscles, the neurons are active, and they are playing an important role to preserve the physiology because of the pathology the patient has. Apart from the central control of the central centers which exist, there are central chemoreceptors. As we know that the cerebral circulation is separated from the brain by a blood-brain barrier, which means the H ions and the bicarbonate ions are not able to penetrate across. So to govern the respiration, there is an indirect mechanism. The CO2 which rises, or the CO2 which is there in the blood, diffuses across the blood-brain barrier, comes to the CSF, and here it combines with the water present, produces H ions and bicarb, and then these H ions are able to act on the central chemoreceptors. So it's by the mechanism of the CO2 rise which governs the respiration because of the penetration of CO2 through the CSF and then coming back to the central chemoreceptors. So just to summarize the whole control of central and peripherals, remember it is the pons and the medullary centers which are there in the brain, but on top of it is the brain which has higher centers, the cerebral cortex, which can actually increase or decrease the ventilatory drive because it has got voluntary control. The other one is the hypothalamus, and they have receptors of pain and emotion, and they act onto these centers to produce, increase or decrease the ventilatory rates. As I told you, the stretch receptors are there in the lungs, and they inhibit the inspiration from going further. So they limit the chest expansion to what it should be normally done. There are irritant receptors present in the airway, so that you will not be able to breathe when you are coughing. The breathing stops at that time, so it inhibits respiration during the coughing mechanism. There are receptors or stretch receptors which are placed in the joints and the muscles, and when they stretch, they actually stimulate ventilation. And last but not the least, you have hypoxia, acidosis, and hypercapnia. These conditions act through peripheral chemoreceptors and also stimulate ventilation. So this is a kind of a summary of how ventilation is controlled by the central and the peripheral mechanisms. The central receptors I've already described, the acidosis and the hypercapnia, how they act. Now let's talk about the interplay of pressures, how pressures play a role in movement of the air across the airways. This is at rest. The interalveolar pressure is about 0, which means it's equal to the barometric pressure outside. And the interpleural pressure is minus 5 centimeters of water. Do we have a pointer, please? So you have an interpleural pressure which is normally stable at minus 5 centimeters of water, and at stable conditions when there is no flow, the mouth pressure is equal to the barometric pressure. That's why it is set at 0. So now once the inspiration has to occur, the first thing which happens is the diaphragm descends down, it becomes active, and because the diaphragm descends down, you will find that the interpleural pressure decreases from minus 5 to almost minus 7 centimeters of water. So with the pulling of the diaphragm down from the thoracic cage, a negative interpleural pressure is increased, and therefore this pressure is transmitted to the alveoli. The alveoli pressure also becomes negative. So when the alveolar pressure becomes negative at the inspiration, then the airflow from the mouth occurs via suction mechanisms into the alveoli. So the air will now move from mouth to the alveoli because there is a pressure gradient which is created. The alveolar pressure is minus 2 or something like that. As soon as the alveoli retain their normal shape or they are full and the pressure in the alveoli matches that of the pressure in the mouth, the flow stops and there will be no flow, and that is at the end of inspiration when the interpleural pressure is maximum. Now let's switch over to the expiration part. During expiration, the diaphragm is now going to be pushed into the thoracic cavity. So once the diaphragm is pushed into the thoracic cavity, the interpleural pressure becomes less negative, and there is a positive pressure applied to the alveoli which are already full during the end inspiratory phase. So the intra-alveolar pressure becomes positive. It is positive than what is there in the mouth, which is 0. So once the intra-alveolar pressure is positive, the air transgresses from the alveoli towards the mouth and expiration process is completed. And at the end of expiration, the alveolar pressures again would be 0 and the interpleural pressures will return back to normal, that is minus 5. So this is how the movement of air occurs because of a pressure gradient which is applied by means of diaphragm going into the abdomen, creating a negative pressure, more negative pressure in the pleural cavity and thus in the alveoli, which allows alveoli to expand. To understand this and the other effects of compliance and resistance, so the pressure gradients are the one which drives the airflow into the lungs, and that occurs from the mouth to the alveoli so that the alveoli can expand. And this is because we have already shown how the pressure gradient works across the airways between the mouth and the alveoli to expand the alveoli. Then there is a transpulmonary pressure. We were talking about interpleural pressure, which is -5. This is a pressure across the alveoli, not across the airways. And the third one is the transthoracic pressure, which is across the chest wall, right? So these two pressures, the transpulmonary pressure, determines the lung compliance, whereas the transthoracic pressure, which is across the chest wall, determines the chest wall compliance. So we just need to remember this mechanics, how it happens in the normal airway. Now all these things have been explained very well by a butterfly diagram. On the right hand side is the physiology of respiration and how this physiology of respiration can be managed by artificial ventilation or mechanical ventilation is onto the right side. So let's understand the basic physiology of this. The alveolar, the compliance, the chest wall and the lung compliance determine the total lung compliance. The alveolar pressure range is the difference between the pressure in the alveoli at the end of inspiration and that at the end of expiration. So this is the alveolar pressure range. The compliance and alveolar range determine the tidal volume which the patient is going to receive. Remember, if you remember the definition of compliance, it's the unit change in volume per unit change in pressure. So what is this unit change in pressure which is producing a tidal volume? It is nothing but the alveolar pressure range. And the alveolar pressure range is the difference between the pressure in the alveoli at the end of inspiration to that at the end of expiration. The end inspiratory pressure, which is this, is determined by or is primarily influenced by the pressure in the mouth, that is the atmospheric pressure, and when the patient is breathing spontaneously, and the pressure difference across the airways. So it's dependent upon two factors, the pressure at the mouth and the difference in the pressure or the airway, the pressure across the airways, that is during the inspiratory phase. So this difference between the airway pressures between the mouth and the alveoli is defined as the end alveolar inspiratory pressure. And similarly, it is for the expiratory phase where the end expiratory pressures are determined by the mouth pressure, which is generally a 0, and the pressure gradient or the pressure difference across the airways. Now these pressures are required to generate a flow, to create a volume. So this pressure difference which occurs across the airways produces a volume, and this volume of the gas has to move from the mouth towards the alveoli to generate a tidal volume. But the flow of the gas to occur across the airways is determined by the resistance. And this resistance, if it increases, then the pressure difference across the airways will also have to increase to get a similar volume which is required in normal time to reach the alveoli. And to get that increased pressures or increased negative pressures to overcome the resistance, there is an inspiratory muscle force which is produced, and that is why you will find that patients who have respiratory distress would be or who have COPD or increased airway resistance or decreased compliance would be generating an extra inspiratory force to accomplish the inspiratory phase of respiratory cycle. And once this pressure difference is high, similarly you will find that you will have to generate an extra amount of expiratory effort to overcome this increase in pressure difference to expel the air out of the alveoli or the airways towards the mouth. So this is the right part, this is one part of the butterfly which I have just explained to you. The other one is the mechanical ventilation, how it is influenced. If you look at the normal pressures which are there in the airways, the end inspiratory alveolar pressure is about -3, that is during spontaneous ventilation, and the end expiratory pressures in the alveoli are +2. Therefore, the alveolar range is about 5. That's the alveolar range or the pressure between across the airways, which helps the air to move in and out of the alveoli. Now, when we know the pressure range, and if the compliance is about 100 ml per centimeter, the tidal volume will automatically be about 500 ml. And this, in fact, with the respiratory rate, gives you the minute ventilation of 6 liters. Now, what is important to understand that the mechanical ventilation also produces similar kind of an effects to match this pressure differences and the time frame to achieve alveolar ventilation. So, if you look at this diagram, there is frequency, there is tidal volume. You can set either one of them, but when you set the frequency, you can either put an IE ratio, what should be the inspiratory time and what should be the expiratory time. In some ventilators, you will be able to put the inspiratory time, and then according to the respiratory rate, the expiratory time would be adjusted. So all this interplay of pressures and the time which is required matches this part of the butterfly to give you the proper ventilation. So in respiratory failure, which can occur either because of decreased compliance or increased resistance, there will be a fall in the inspiratory tidal volume because there is increased pressure difference. And when there is an increased pressure difference, the inspiratory muscle force has to increase. And this will enable some of the gas to meet the volume which is required into the alveoli. And if it is not met, then the frequency or the rate of respiration increases, and that is when we call the patient has gone into respiratory distress or failure. Now let's come to the other part or the inherent components of lung or mechanics. There are 3 components: elastance, compliance and resistance. Now the compliance is reciprocal of elastic recoil. So both are opposite to each other. What does compliance mean? One, we talked about the alveolar pressure range, right? And the chest wall and the lung compliance. So it is basically a unit change in volume produced by the unit change in pressure. The elastic recoil is just the opposite. That is an inherent property of the lung to recoil back to its normal position. And how is the lung kept in a normal position? Why is it not allowed to collapse inside, which is its normal inherent property? That is because of 2 factors. The chest wall has the ability to move outward, while the lung has the capacity or an inherent property to move inwards. So to bring them both together at an equilibrium, there is an interpleural pressure which is -5 centimeters. So this interpleural pressure makes sure that the lung is kept expanded in all areas, and it differs from the base to the top, and the chest wall is kept in its equilibrium position to match the lung compliance. And out here, if you look at the compliance curves, this is the one which we talk about the lung compliance, the pink one. And the green one tells you about the thoracic compliance. So to get them all together, you get a total compliance, and the point at which they are at equilibrium is the functional residual capacity. So the functional residual capacity would be where your lung compliance and the chest compliance are at equilibrium, so that the chest is normally expanded. The lung compliance now is determined by 2 factors. One is the tissue elastic forces, the other is the surface tension. So the surface tension in the lung is governed by the surfactant, and the pressure gradients which we talked about determine also the alveolar volume. So both of them are equally responsible. So let's talk about first about the surface tension. The surface tension in a liquid, if you look at, is because of attraction of the molecules, and they form a firm bond at the fluid film, and that creates a surface tension, and that tension is required for most of the liquids. What does soap do? It basically decreases the surface tension to produce that kind of a foam. Now let's take that, translate that surface tension into the alveolus. As I told you, that this is governed by the Laplace's law. There is a distending pressure which is required to keep the alveoli in a stable or an open phase. There is generally a collapsing pressure which will tend to collapse the alveoli because that's the elastic recoil property of the lung. Now, to make sure that this inherent property of the alveoli to collapse is prevented, you require a distending pressure, and that is what is written here. It is proportional to the surface tension and inversely proportional to the radius. To understand this in a little better manner, let's consider a large alveoli and a small radius alveoli. So there is the air-liquid interface here. Now,